You should.
Welcome, welcome,
Hold on one moment. Let me.
welcome
Okay.
in, everyone. Welcome to Care Concierge with Care Patrol, where education is the heart of everything we do. I do appreciate you all sticking around. We were late today. I had some technological issues. The beauty of doing online courses is that you get to participate and be a part of something while you're at a different location than we, but it's also sometimes the frustrating part when technology doesn't quite translate. As most of you know, we are accredited by the Alabama Boards of Nursing and of social work. We've just reapplied and been reaccredited with each of those entities through 2028 and 2030. And we are so proud of that honor, and we love to bring you education. It's what we do with Care Patrol, with our clients, educating them about their options, their cost, and what to do next. And we like providing education to you to give back. Um, our presenter today is Dr. Kwajalein Nicole Brown, a frequent presenter of ours. This is 1.0 contact hour, and it's a clinical hour for those of you that need to make track or take note of that. And for social workers, this is considered a live hour because of our password protected evaluation that you must do in order to receive a certificate. Nurses will post your hour for you. Our online survey link, I'll read to you now for those who need to know it, who are either watching this online at a later date or just at your desk. I'll read to you the link, which is www.surveymonkey.com/lowercase r/uppercase letters with numbers Y, T as in Tom, T as in Tom, W, V as in victory, 9R. That is the link. We'll give the password at the end today. This is password protected. And now we'd like to welcome you, Dr. Brown. So eager to hear what you have to say.
Okay. Well, hello everybody. So, I have a question. And that question is, how many of you have ever disagreed with a diagnosis another clinician has given? Put that in the chat. How many of you have looked at a diagnosis that somebody else has given and gone, not very sure?
Every day, absolutely.
So, I want you to also think about, have you ever fully felt like the DSM really captured what was actually happening with your client? So, for housekeeping purposes only, I wanted to put credentials and let you know that, of course, my name is Dr. Brown, and I always start my presentations by letting you know why I'm qualified to have this conversation with you. So, I'm being transparent and letting you know why I am qualified to have this conversation with you. And hopefully, this is a conversation because it's one that I deal with in my daily life. I am a clinician and I am the principal owner of Compass Rose Behavioral Health. So I do a lot of assessments and I see a lot of um, assessments and documentation that comes from other clinicians. So the DSM is what I do all day. I build DSM and I do assessments for things like autism and do forensic assessments. So I see DSM a lot. So I'm very interested in that. So DSM is like my second Bible. Well, it's like, yes, my second Bible. So here are our objectives for today. This is what I intend to, in our hour that we talk to each other, we get to go through. I'm going to try to go as fast as possible because I have a lot of information. However, I will still send all of my slides to you. I'm going to try to go as fast as possible. But also, if you have a question, please stop me so that I can answer those too. So the DSM.
I'm sorry. I was just saying I'd read those in the chat room for you.
Okay. Wanted to note that in May, it is Mental Health Awareness Month. But I think we all know that. And so I want everybody to, like, for participation, put a thumbs up if you feel the mental health conversation that we have on a daily basis, if mental health is more acceptable now than it was 10 years ago. Because awareness has increased dramatically, but the awareness doesn't necessarily mean equal understanding. And despite more diagnosis and more screening and more treatment, we still have the debate about what mental illness truly is and what constitutes pathology and whether our diagnosis system reflects the biology or consensus of our whole. So our DSM is they see it more as a screener, because the DSM evolved from psychoanalytics and it's descriptive, and it moves towards symptom-based operational criteria. And it's important to know that the DSM does not claim diagnosis or biologically verified diseases. So many clinicians assume psychiatric diagnosis work like, well, we do, but most people outside of what we do don't think about diagnosing like medical diagnosing. Like if you had diabetes, you would go to an endocrinologist and you would get these things done, and this is how it will be done. Well, in mental health, that doesn't necessarily always work that way. So sometimes mental health has this stigma that, you may have anxiety, you may have depression, but most people won't do anything about it. It's not necessarily considered a medical diagnosis like diabetes. So like if you had diabetes, for example, you would take some type of insulin or something to bring your blood sugar down. But in our world, if you have, I don't know, multiple, like an anxiety disorder, sometimes there's so many different paradigms that you can go down that people would be able to do. Medication, you could take the alternative route, you could take the CBT route, but there's no specific boom, boom, boom of this is what will be done. So psychiatric diagnosis, we largely lack defined biomarkers. I'm gonna make sure that everybody understands what I'm saying. Oh, and what I wanted to tell you was in the DSM, and now in the DSM TR5, we have prolonged grief disorder that was added, and there are several different codes for that. Because what was happening was people were coming in with, grief. Things were happening in their families. They were losing loved ones, and there was no way to really capture what was going on. And whenever we're giving diagnosis, remember that we're supposed to use a CPT code and an ICD-10 code. And what a lot of people were doing was using adjustment disorder, because you can only use it for so long. And you can use it with a code for grief, but at some point you have to take it off. right? So what they did was they continued with prolonged grief disorder, and then they updated language surrounding gender and culture. So they kind of took out some words that they felt offensive to some people. And so, especially in the LGBTQ community, they were kind of conscious of those things. They clarified suicide risk and coding language for this. So they were trying to make sure that we were able to largely capture what was happening in therapy. Okay, let me tell you what the DSM is missing right now. It categorizes mental disorders based on observed symptoms rather than underlying biological markers or the causes of the biological markers. So causation is taken out. But we still lack definitive medical tests such as blood testing or brain scans to validate the vast majority of the psychological diagnosis that we're using. So basically, there is no science behind anxiety. There is no science behind depression. I'm talking about this both sides of my neck here. We know that there is research behind it, but what I'm saying is the biological markers that are attached to that. There is no DNA marker that is attached to anxiety or depression, like there would be for other medical diagnoses. And we would like to see that because there's research behind that, but the DSM doesn't address those things. And it doesn't allow us to think about what other biological markers that there can be. And because of that, sometimes we miss initial assessments. And sometimes when patients come in, we only get that one time, or we may get 2 or 3 times, depending. So the big question here I'm going to ask a question. Do you feel like DSM diagnoses are real diseases or illnesses? Or what would you say that they are depending on what your beliefs are? Because 2 clients with major disorder may share one overlapping symptom and receive the same diagnosis. Does that seem fair? Does this change how we conceptualize the diagnosis? What are we thinking? Because most DSM diagnoses are diagnosed by symptoms, by clusters, by what the patient reports. But we don't use any imaging, any brain scanning, any diagnostics, any genetics for that. So like I said, 2 people can meet the same criteria while presenting differently. Because when we're using criteria for a diagnosis, you have to have 2 or 3 out of this, 2 or 3 out of this, and 1 of these. And if you meet any of that criteria, then you come to this conclusion. All right, let me tell you what else the DSM is missing. Validity. A fundamental characterization symptom. We still lack a clear, universal, agreed upon way to measure how a psychiatric symptom overlap and why distinct disorders often share the exact same genetic and environmental risk factors. Anything in the chat yet? I want to make sure I'm not losing anybody.
One who said fair or not, it's occurring, it's real.
Yeah, because in my past life, I was a nurse. And what we were taught was if the patient says, we asked them about their pain scale, whatever the patient said their pain scale is, that's what it is. The patient said the pain was supposed to treat it like it was a 10, right? But when we see two different patients and we see two different patients, the diagnosis is anxiety disorder. It looks different in both patients. It looks absolutely different in both patients. So validity here is an issue. And what I'm saying is the distinct criteria, the DSM, they improved validity by standardizing criteria. But criteria does not automatically mean it's valid. And the example is if every clinician consistently labeled grief as pathology, reliability improves even if the conceptualization is flawed. It's like a big old handful. But the strength that has come out of the DSMTR is improved validity over earlier versions. The earlier versions didn't really give us validity. However, we do have that now. And that means, and that kind of remains controversial sometimes. So some in the psychiatric world, some people believe that the DSM has reliability, but it is not valid. So there's still like a push and pull about what's going on with the DSM. A lot of people would like to see more more research in the DSM so that we can provide not only reliability but validity for our patients and for our profession. So again, the problem is that symptoms overlap. Major diagnostic overlaps exist between PTSD and ADHD, or even ADHD and autism. So, for instance, I see a patient that is came to me diagnosed with autism and anxiety. Well, their symptoms overlap. There's like this, there's like an overlap in the circle, and there in the middle is what's going on with my patient. And let's be honest, sometimes we inherit diagnoses that we don't quite agree with. But what are we supposed to do about that? That's where the assessment comes in. And we'll see trauma diagnosed as bipolar at least one time. And that's because we really have to get in and really talk to our patients. Because if we're using the DSM only without interviewing and having a good assessment about what's going on with that patient, we'll miss a lot of things. And we're trying not to miss things. So sometimes the chart says one thing, but the client sitting in front of you tells you a completely different story. So although there are shared symptoms, it is up to us to tease those symptoms out and make sure that we are doing a good job with our assessment, because the DSM provides us with wiggle room with how we will make diagnosis for patients. So like I said before, you can have two patients with PTSD. They look totally different. Their representation and their presentation are totally different. So then what are we doing? And how are we using the DSM to distinctly make sure that we are giving a clear picture to insurance companies? Because basically what we're doing is the patient is presenting to us, we're doing our assessment and our interviews, and then we are required to use CPT codes and ICD-10 codes from the DSM to make sure that we are describing what we're seeing in real time with that client. So trauma, which is one of my favorites, like I love seeing patients that have, you know, compounded trauma, any type of trauma, and you hear trauma a lot anywhere. But trauma is a diagnosis that has I would say is a chameleon. And here's why. The diagnosis, what disorders have you seen over and over that have been diagnosed? I bet you've seen ADHD. We're seeing a lot of anxiety disorders. We're seeing a lot of depression. We're seeing a lot of autism too. Does anybody agree with that are doing diagnosis? And this is especially relevant when we're talking about making diagnosis for example, children that are in foster care or that are in schools or that are in juvenile justice systems or inpatient settings. Because we're looking at the patient and sometimes we have to do a quick assessment about what's going on. But do we ever really think about what may be traumatizing that patient? A trauma-informed assessment is essential. Sometimes we're missing that. And trauma can look like bipolar. It could be exacerbating what's going on with that client. So assessment is key. And the DSM does not account for trauma when diagnosing patients with autism or bipolar disorder. Trauma is not a criteria that we can choose from.
Dr. Brown, we have a comment from Samantha Sims who says, it's because all psychiatric illnesses are human illnesses.
Mm-hmm.
And just like your pain example, patients experience and perceive symptoms differently.
Absolutely.
Factors such as trust in medical authority, culture, age, education level, socioeconomic status, etc. Another example about bipolar diagnosis being inappropriately diagnosed is with patients with substance use who have not been abstinent long enough to have clear thinking and more appropriate behaviors.
Absolutely. So thus is exactly what I'm saying. The DSM does not account for those things. It doesn't account for, people that are coming off of substances. It doesn't account for trauma. It talks about trauma. Trauma's in there, right? But when we are tasked to go through criteria and choose through our assessment what is going on with that client, trauma is not an option in any of the criteria. But for bipolar disorder, it's not an option. That this bipolar disorder could be a contributing factor could be trauma. You have to use Z codes for that. And most times, those are not, they look at them in the insurance companies, but it's not one of those things that are really looked at. So again, the DSM is missing the mark when they don't account for trauma for anxiety disorder, most definitely, because you're going to see a lot of clients who are traumatized and they have anxiety disorder and they're anxious because they're traumatized. But that is not a part of the criteria that we can choose from to describe what's going on with that client. Okay, I want to talk about culture. And the reason I want to talk about culture and bias, racial bias, and I'm going to go by it pretty quickly, is because when I was in my master's program, they really harped on culture. You cannot diagnose any client with a mental health disorder if it is related to their culture. There are a lot of patients whose culture are different than ours. And because of that, they may see that they saw their dead grandma or their dead grandma came to them in their dreams. Some people may say that person was hallucinating, or they may say that they see auras or they see spirits or they feel energy. Now, some people may say that's psychotic. Other people may say it's not. But if that is a part of that person's culture, although you may not agree, you cannot ethically say that patient has a mental health disorder. Culture shapes emotional expression, and the DSM misses this. Distress, language, spirituality, how they cope. There are people that are practicing things like Santeria, where they have orishas, and that is something that is not necessarily in mainstream culture, and you may not understand it. And even though you do not understand it, you cannot give a client a DSM diagnosis based on their culture or their cultural beliefs. African Americans are disproportionately diagnosed with schizophrenia because of this. Because there are in culturally, people may say that they have seen or people have come to them or they see certain things. And you know that when we're talking about schizophrenia, we're asking people, do you see things that are not there? Do you hear things that are not there? And based on culture, if somebody said, yeah, I see my dead grandma comes to me in my dreams, or she sits with me while I pray, or I hear the voice of such and such who's passed on. Technically, auditory and visual hallucinations would make criteria for schizophrenia. So the neurobiology gap here. This is where neuroscience becomes really exciting. Psychiatry and the mental health field is increasingly moving away from rigid categories and moving toward dimensional modes. So you may see things about potential biomarkers soon, or neurocircuits based diagnosis. So mental health disorders may include overlapping neural networks or inflammation pathways, right? So we have people with chronic pain. That's where I'm thinking about that. People with chronic pain, or people with Ehlers-Danlos syndrome, right? So sometimes your nervous system, if it's not working correctly, can show up as a mental health disorder. Your nervous system may be so sensitive based on inflammation markers that it would show up as or present as a mental health disorder based on our criteria. And to be honest with you, DSM is missing the mark there. I myself am an autoimmune patient. I have inflammation symptoms, and I have neurofeedback symptoms at times. If I were to go to somebody who was not well-versed or knowledgeable or open to those things, I may show my presentation at the beginning of my assessment may mean that I present as someone who may have some type of blank disorder, just depending. And think about our patients with schizophrenia or bipolar, and how the neurofeedback that happens with them, how that might affect them. But the DSM does not account for that. All right, medication debate, which is a big one. Whether to medicate, not to medicate. When does suffering become a disorder? Because there are some ethical and contexts that matter here. Remember when I was talking earlier about your culture? If you see your dead grandma, does that mean that you need to be medicated? If you hear, I don't know, some people say they hear angels talking to them, does that mean they need to be medicated? If they're in grief and it's taken a long time for them to get over it, does that mean they need to be medicated? DSM doesn't tell us anything about that. It doesn't tell us about social anxiety and how we're supposed to, should those people be medicated? And in some ways, excuse me. Okay, sorry about that. Let's try this again.
One of those days, I think, Dr. Brown.
It's one of those days, but it's
okay. It is a beautiful day.
in the
I'll give it
neighborhood.
that. Yes. I used to want to be Mr. Rogers when I was little. Or Rock.
He's
What
a
was?
cool guy. Would you
Yeah.
be mine? Could you be mine? Won't you be my neighbor?
Yep.
So I was talking about medicalization, the debate about whether to medicate or not to medicate and when it's appropriate. DSM doesn't talk about that. It does give us a little bit of information, but it doesn't cover it at all.
Okay. Your PowerPoint is not back up, just FYI.
It's not? Oh,
No.
good Lord. Let's see. Let me try this again. That's not supposed to be happening. Sorry about that, y'all.
Now we've got you and
Oh,
me.
that's fine. Hello. Let's try it again. What do you see?
Insurance reality.
There we go. Let's
All
go,
right.
y'all. Because in order for us to get paid, we have to make a diagnosis. That's it. In order for us to get paid, we have to make a diagnosis. And the diagnosis has to, because it has a diagnosis, that correlates to how much money you get paid. Right? And insurance says you have to have a diagnosis. And whether you see a patient and you think nothing's wrong with them or you're not sure what's wrong with them, what has to happen is we have to give them a diagnosis. So whether that's adjustment disorder or whether that is prolonged grief, something has to happen there. And for most people, what we do until we are sure is adjustment disorder. And this like the insurance debate resonates a lot with social workers and nurses, because of what I just said. We have to put a label on people in order for us to be paid, and we have to do it very quickly, and we have to justify it. But sometimes clients don't fit certain categories. So the ethical question is, does reimbursement shape diagnosis? Because in some places, depending on the diagnosis, you get paid more. Just a thought. All right. In neurodiversity, there's an emerging conversation about autism and ADHD and sensory differences. And the concern about overdiagnosing the neurodivergent in the neurodivergent community and whether it should be, especially with children who are small. And most people want to know, because that child is not speaking at a certain time or not talking at a certain time or not walking at a certain time. Most people are very scared, and what they're doing now is they're really thinking their child has autism or there's something wrong with them. And the balance for us is to make sure that we're allowing for the child to grow and for the brain to grow, so that those neural pathways can be connected. And when they are connected and at the time that is right for the neurodevelopment of that child, then they will talk. However, when we do have children in front of us for Medicaid purposes, for any purpose, like I said, we have to give a diagnosis, for us to be paid. And like I said, the emergent conversation is whether or not these diagnoses are being overly done at this point. personality disorders. So who believes personality disorders are amongst the most misunderstood DSM diagnosis? Because trauma can overlap here with personality disorders. There could be attachment disruptions or developmental adversity here, but they can be really misunderstood as personality disorders. The DSM doesn't give us options for this. It doesn't tell. It's boom, boom, boom. What's going on? We don't really get to tell a good picture here. There's stigma attached to this. And let me tell you something about personality disorders. Once they go on a patient's medical record, which your mental health record is a medical record, it cannot come off. All personality disorders, once they're there, they are there. And let's think about this in terms of when patients are going to get life insurance. For instance, I told you I have an autoimmune illness. Because I have an autoimmune illness, I don't qualify for whole life insurance. When you provide a personality disorder for a client, it is going to be hard for them to get whole life insurance. Did anybody know that? Okay,
Miss Sim says no, she did not know that, but otherwise, yes, I knew that because I was denied it for high blood pressure.
Mm-hmm. Insurance companies are most definitely prevalently denying clients, especially for personality disorders and for suicide attempts if they are documented. So it is important for ethics and liability and the liability discussion to talk about suicide and emphasize risk assessment, reduce risk altogether, but it does not eliminate uncertainty. I did not know that if you have a patient has a documented suicide attempt, that they will be dropped from their whole life insurance once it is reassessed. I did not know that. And the DSM talks about suicide, but I would love for it to have, and a lot of clinicians would love for it to have more information about it so that we can say, okay, in the description of how we did the diagnosis, we can say, okay, this person had an attempt based on this, but the patient is stable, because sometimes they can't even get health insurance if they have a suicide attempt. There are some companies now that are saying, okay, well, based on your diagnosis and based on what has happened in inpatient, this patient is no longer eligible for health insurance or whole life insurance. So we need to look out for how we are documenting, and it's up to insurance companies to make that right. The DSM does not really talk about suicide and suicide prediction. It doesn't talk about how we can document to help patients on that other end, because remember what I said, the DSM doesn't talk about the medical side of mental health. It only talks about categorizing what's happening or describing what's happening. So the DSM doesn't really talk about emerging future directions either. And it doesn't talk about, technology may improve so that we can that'll help with screening and pattern recognition. Maybe AI will do that for us too, but that's for another day. But emerging in the future, AI can't replace therapeutic relationships, cultural understanding, or human clinical judgment. DSM doesn't talk about this. They'll probably do a revision and may have a discussion about it. I want to talk about burnout amongst our our profession, think about how the current mental health system has impacted your mental health and how it has caused you to react to making those diagnoses and making those how it affects you, because we have a lot of times where I have a lot of colleagues that say once they're done for the day, they don't even want to talk to anybody. They don't want to talk on the phone. They don't want to text. They just need to sit there because compassion fatigue sits in. Secondary trauma sets in. There's document overload. And when it's time for you to make those diagnoses, you're really not thinking about all that stuff. You're like, okay, you meet this criteria for this. But then also, you have to document. You have to do the treatment plan. That's a lot for all of us. So let's think about a couple of pearls here. We want to diagnose cautiously. We want to formulate comprehensively. Consider trauma. I'm asking you to consider trauma before you make your final diagnosis, and assess for culture. Ask people about their culture, and just treat the person, not the code. Trying to find a code, because sometimes we're missing things because we don't have the time to sit and really talk to patients and try to figure out what is happening. And the DSM doesn't give us a lot of wiggle room to describe what's happening. So we're using it as a tool, but not as an absolute truth for what's going on. Okay, I have a case example. So we got a 14-year-old that presents in this manner. My question is, what's the differential diagnosis? Anybody?
They're typing, I'm sure. Ray, your previous slide, Lisa Smith had said a broken system threatens to break us.
Absolutely. That's why we create support systems amongst ourselves.
Diane
And
Hunter
have support
says
systems.
social withdrawal is the 14-year-old.
Mm-hmm. And when we're looking at children, please think about brain development. The DSM doesn't account for those things. It talks about it in the beginning, but it doesn't really, the way that the DSM is set up now, it has all the childhood diagnosis at the front, and then it goes from childhood up to adulthood, and you can pick and choose and take what you need. But all the childhood diagnoses are at the front.
Jessica Hoggle says, need to ask about history of trauma and ACEs.
Absolutely. Thank you. Absolutely. Good clinicians will tolerate uncertainty before assigning a label. This is all I want to say here, is that before we assign a label, we think about the uncertainty. And we think that the DSM is a map. We think of it as a map. The most dangerous clinician is not the one who lacks knowledge, but the one who believes diagnosis is absolute. So causation. We think, oh, this is what's wrong, but be flexible and fluid. Let's talk about TikTok. I really want to talk about TikTok real quick. Because of the era that we're in, we have a lot of people that are going to TikTok and other social media to think about their diagnosis, and then they bring it to therapy. So have you noticed an increase in clients presenting with diagnoses that are discovered online? Because I have a lot of people that come to me and say, hey, I think that I have autism. I was on TikTok and this is what it said.
Yes, and due to Chat GPT.
Oh yes, Chat GPT. If you talk to it long enough, it'll tell you a whole bunch of stuff that may or may not be true, right? So these algorithms reinforce content for people, and if they watch long enough and they're liking long enough, you'll get people coming in talking about, "Hey, I think I have ADHD," or "My such and such has narcissistic personality." They're using a lot of these buzzwords like trauma bonding and talking about that in clinic, and it is like wildfire. It's bad. And I have to go back and reteach in clinic with my patients and tell them and explain to them exactly what trauma bonding is or exactly what narcissism is, because they have gone on the internet and the internet has told them that they have narcissistic personality disorder, or they now have PTSD, or they believe they have autism, and or they're introvert or extrovert, or these new words that are coming up, and they're definitely getting them offline. um the DSM doesn't talk about that, but I believe I know in the revision they're going to have to talk about it. They're going to have to talk about social media and self-diagnosis, and it probably will not give us a whole lot of direction on what to do, but they're going to have to discuss it. The DSM misses. The manual cannot fully answer where normal psychological struggles end and mental health disorders begin. So the critics point out that this frequently leads to diagnosis overload or overpathology. For everyday emotional pain and grief, there's just a diagnosis for that too. So making the line between clinical pathology and human experience is subjective. So people don't like to be in pain. They want a name for whatever is happening to them, whether that's a bad breakup or loss of a pet. People want to know, they want a label put on it. So what diagnosis do you think is frequently misdiagnosed? Because differential diagnosis among clinicians, depending on who trained you and where you were trained, we are not all trained the same. It's just what it is. There's no continuity across the board, right? So we're using the DSM to make it continuous across the board. However, your interpretation of what different criteria is will depend on what will happen and how that person will be diagnosed. I believe anxiety disorders and depression is diagnosed the most. There is a gender gap that cannot be ignored. The DSM, when it was originally written, was theoretically for white men. And some of the diagnoses were put in there to describe hallucinating African Americans or things that they did not understand. But even in that, many women with ADHD or autism could present differently, and they're missing the mark there because the DSM was set up in such a way that described more white males and their behavior patterns. And it did not look at the behavior patterns of women. So women are disproportionately being forgotten for ADHD or for autism. ADHD and autism, perfectionism, anxiety, emotional exhaustion, sensory overload, those things are very prevalent and they're being missed in women. There's an autism explosion. The DSM does talk about autism, but because now it seems like it is being very much so diagnosed a lot for a lot of children. I've personally observed that there have been a lot more children presenting with autism spectrum disorder as their assessment. But it's a nuanced discussion. So we try to avoid framing increased autism diagnosis negatively, but improving awareness.
Keldon Jones has a question. PCOS Pros is now saying neurological. What are your thoughts on this?
I don't rule it out, to be honest with you. I don't rule it out. I could see where it would be a neurological issue, and I could see where people would want to categorize it, but and put it in a category, assess it, and put a diagnosis to it. I think we need to be cautious because there are other things that are driving people's mental health, but the DSM does not account for those things, and it makes it hard for us to walk that line and make a diagnosis. And I've talked about this, about inflammation in the brain. Inflammation in the brain from several different diseases can really sway what the diagnosis is. So we definitely have to be careful about that. I'll put in there immune disorders. I put in there PANS and PANDA.
Apparently, Dr. Brown's computer crashed. So I'll post in the chat room again our link and and password, which is diagnosis or diagnose rather. The link for those of you watching on video or who didn't hear it earlier is www.surveymonkey.com/r/all uppercase letters with numbers Y, T as in Tom, T as in Tom, W, V as in Valerie, 9, R. And the password today, which you must have, is diagnose with a capital D, lowercase IAGNOSE, diagnose. Thank you all for being here. Thank you for weathering our technological issues today. And join us on June 2nd when we will be with you again live. And the topic now escapes me, but hopefully it'll be one that will be pleasant for you. Thank you for all that you do. Thank you for joining us. Hope you have a great day and a great couple of weeks ahead. And thank you for your support of Care Concierge with Care Patrol. Y'all take care.